Sophia Gutierrez, PsyD clinical psychology doctoral student, California Southern University. Today I'm going to explore panic disorder through the lens of emotion and motivation. And so rather than only defining panic disorder behaviorally, I will explain the physiological processes involved, the role of the sympathetic and parasympathetic nervous systems, the neurobiology of fear, and how these mechanisms inform evidence-based treatment decisions. I'll also touch on how interventions may differ across populations and culture. Panic disorder is not simply someone having anxiety. It is a dysregulated fear response rooted in core emotion systems that are designed for survival. Here we're looking at the physiological processes, and this is a very basic map. Panic disorder involves activation of the brain's fear neurocircuitry, particularly the amygdala, hippocampus, and medial prefrontal cortex. The amygdala detects threat and activates downstream systems responsible for the fight or flight response. Sensory information travels through both a fast low road directly from the thalamus to the amygdala and then a slower high road involving cortical processing. In panic disorder, this system appears hypersensitive, and that's because there's an exaggerated amygdala activation combined with insufficient top-down regulation from the prefrontal cortex, leading to catastrophic misinterpretation of bodily sensations. Some of these physiologically can include increased heart rate, hyperventilation, sweating, trembling, extreme fear, HPA axis activation, and more. These are adaptive fear responses that become maladaptive when triggered without danger. Here we're looking at the human nervous system, particularly the parasympathetic and the sympathetic nervous system. The sympathetic nervous system mobilizes energy for survival. It's what increases heart rate, dilates pupils, redirects blood flow to muscles, and stimulates the adrenaline release. The parasympathetic nervous system promotes the rest and restoration in our body. And during a panic attack, there is excessive sympathetic activation and insufficient parasympathetic recovery. The locus coeruleus, a major norepinephrine center in the brainstem, plays a key role in sympathetic arousal and has strong connections with the amygdala. Emotionally, this creates a powerful state, escape. The body is preparing for action, but there is no actual predator. There are several neurotransmitter systems implicated in panic disorder. Norepinephrine, hyperactivation of the locus coeruleus increases the norepinephrine release, and this contributes to the cardiovascular and respiratory arousal. Then there's serotonin. Dysregulation in these pathways, particularly from the dorsal raphe nucleus, may impair inhibition of fear responses. Then there's the GABA. The GABA is the brain's primary inhibitory neurotransmitter, and reduced function there may lower the threshold for panic activation. Then there's the HPA axis. Corticotrophin release factor activates cortisol release, reinforcing stress activity. The combination of heightened excitatory signaling and insufficient inhibitory regulation contributes to the panic vulnerability. Here we're looking at the neural pathways, a map showing you the fight or flight response. Walter Cannon described the fight or flight response as a universal survival mechanism. The fight or flight system is hardwired into human survival. Stress events or stressful events are processed both at the cortical level and subcortically through the amygdala. And when danger is perceived, the locus coeruleus, referenced earlier, sometimes referred to as the adrenal gland of the brain, it fires the burst of norepinephrine. This activates the limbic system, hypothalamus, pituitary gland, and the sympathetic nervous system. Adrenaline, noradrenaline, and cortisol are all released, and these processes are adaptive when danger is real, but they become pathological when triggered without actual threat. In panic disorder, this survival circuitry is activated internally. So there's fight, which is the sympathetic mobilization. Then there's the flight, which is the urge to escape. Freeze, which is the behavioral inhibition mediated by prequadrantal gray projections from the amygdala. And panic attacks mirror conditioned fear responses observed in animal models as well. So the body is not malfunctioning, but it's actually overprotecting. What are some potential causes of the panic disorder? Likely develops through a combination of biological vulnerability and also learning processes, as anxiety sensitivity, the fear of bodily sensation, plays a central role. Repeated pairing of physiological arousal with perceived danger conditions the amygdala to, to threat to treat internal sensations as threats. And so Kent et al. Actually describes how these deficits in coordination between the bottom-up sensory processing and the top-down cortical regulation, which we looked at the mapping earlier to that, may lead to exaggerated amygdala activation. Also, potential causes, there's genetic predisposition, early life stress, trauma exposure, repeated trauma exposure, and chronic stress. These may all contribute. Environmental context and hippocampal processing also influence overgeneralization of fear. Panic disorder frequently co-occurs with major depression, agoraphobia, PTSD, substance abuse disorders. There's a shared neurocircuitry that helps explain this overlap. For example, PTSD and panic disorder, they both involve responsive amygdala activation and impaired prefrontal inhibition. Avoidance behaviors may also reinforce depressive withdrawal patterns, so that those will play with one another in terms of behavioral patterns. So here are this slide, is covering, what are the evidence-based psychological treatments. Particularly, I want to point out cognitive behavioral therapy, particularly interoceptive. I've been doing this recording. This is like my 15th time trying to do it, so I'm getting tongue-tied here. This is considered the gold treatment. Basically, this involves intentionally inducing fear bodily sensations in a safe environment to retrain threat appraisal. A recent randomized control trial demonstrated that brief, intermittent, intense exercise used as exposure significantly reduces panic severity compared to relaxation and training effects maintained at a 24-week follow-up. This idea supports the idea that repeated exposure to arousal in non-dangerous contexts reduces catastrophic misinterpretation. And so this treatment directly targets emotion motivation systems by reshaping conditioned fear responses. So when you think of interoceptive therapy, think of it referring to your own perception of sensations from the inside of your body. And so this is your body's internal sense. It's like your awareness of signals like heartbeat, breathing, hunger and thirst, pain or discomfort, gut feelings, temperature, bladder fullness, etc. Regarding medications, the first line of medication is SSRIs and SNRIs. Then there's benzodiazepines. Those are more short term. The SSRIs are going to target the serotonin regulation and help stabilize mood and the fear processing. The benzodiazepines, those are going to enhance GABA inhibition, reducing the acute anxiety, but it is important to note that that could interfere if you are doing exposure-based learning, especially if overused. Medications reduce physiological reactivity, but really it's going to be the psychotherapy that restructures the fear learning. Recommended therapeutic techniques involved what I touched on earlier, interoceptive exposure, cognitive restructuring, in vivo exposure, psychoeducation, even things like breathing, retraining, exercise-based interoceptive exposure may increase engagement and improve long-term adherence. From a motivational standpoint, treatment works by reducing avoidance and increasing the tolerance of the distress. I want to say that again. From a motivational standpoint, the treatment works by reducing avoidance and increasing your tolerance of distress. Avoidance reinforces fear, but it really is the exposure that over time will rewire it, coupled with CBT. Clients may also need things like psychoeducation about their own nervous system, gradual exposure and planning for that, family education, lifestyle support is very important, relapse prevention planning, and really digging into a relapse prevention plan with your client, and it will not be a one-size-fits-all. Because panic involves fear of bodily sensations, reassurance alone is insufficient. Clients must experience safety within activation. It's important to note that treatment may vary across populations. In some cultures, panic symptoms may be misinterpreted or interpreted as medical or spiritual experiences. Language describing heart distress or breath weakness may influence help seeking. Also, trauma history must be addressed very carefully. In older adults, even things like cardiovascular risk must be evaluated before you do things like exercise-based exposure therapy or other types of exposure therapies. It's important to note that in adolescence, that family involvement is usually essential. Exercise-based protocols may be particularly effective in populations hesitant about traditional exposure exercises, and cultural humility is essential in interpreting fear responses. In conclusion, panic disorder is best understood as dysregulated fear circuitry. Emotion and motivation systems designed for survival become hypersensitive. The amygdala, the locus coeruleus, the APA axis, and the prefrontal cortex, they all contribute. Evidence-based treatments, as discussed earlier, such as CBT with interoceptive exposure therapy, really are going to target this circuitry. Understanding the biology of fear also will allow the clinician to design interventions that are tailored to the client, that will reshape the learning, reduce avoidance, and ultimately restore their parasympathetic balance. Panic is not weakness, it is misdirected survival.